really to improve population health, but to do it in, whilst understanding the voluntary and charitable world in which we are all living and working within our community. So we'll be coming to you a little bit later, Lindsay. We've had some apologies today from Neil Lewis, and Rachel is attending in his stead. We will also have Nathan joining us later for one item, and I'm not certain if Liam is online. Yes, yeah. Hello, Liam. Liam is part of our aspiring board members scheme as well, and we have Danielle joining us as well. Just a brief note that myself and Chief Executive Tracy have to leave in about a quarter of an hour's time because we have an urgent meeting that's been called, but we will be returning as soon as that's over. And the other thing that I will flag now, but I'm probably going to speak about quite a lot more later, is that this will be the last meeting for Angela, our finance director. We're all going to miss you hugely, Angela, but I've got a few words I'll say at the end. So, but you can't leave it. Yes, I thought it'd be really nice to note that in advance because of the huge amount of work that Angela does in supporting the performance of the organisation and all the work that she's done actually within this board pack, as she always says. So thank you for that. Okay, I'm going to go straight on to declarations of interest. Is there anything that anybody wants to declare with items on the agenda today?
It's a declaration that's already registered, but obviously with WCVA colleagues here as well as being this board, I am the vice chair of WCVA.
But so you've got two hats on today. That's nothing. So I'm going to go straight over now to Claire, because Claire has been working with Lindsay and WCVA around this strategic partnership work.
Yeah, so thank you very much. And we're so delighted that you're here with us today. It's been a piece of work that I've led jointly with Jim, so I can't take all the credit. And certainly Emily online and Amy, who's in the room with us here, have been working really closely with Lindsay's team, and particular call out to Joanna, who I know sadly can't be with us today, but please give her our best wishes. And we are really delighted. Her and Emily and Amy have worked absolutely, hand in glove on this. So we do have a real good history of working in partnership with your organisation. And this is, I think, the sort of exciting milestone about celebrating that and formalising it. And over the last 4 or 5 months, we've been working really closely with the both teams. We've had 2 really helpful formal workshops to understand where can we get the best out of this partnership for both the benefits of both organisations, but most importantly for the people in Wales. And that has culminated in this partnership agreement, which we want to present to you today to celebrate. And really just for the board to acknowledge the work that's gone into it, the opportunity that this gives us for our IMCP and our long-term strategy. And I think Amy is just going to introduce the work that we've been doing just with a couple of slides, and then I'm going to hand up to Lindsay just for her to be able to give the WCBU lens in terms of the work that we've been doing, and hopefully we can move forward and celebrate this appropriately and do the really good work that we know this partnership can bring.
Dr. and Fawad, thank you so much for this opportunity to present the Wales Council Voluntary Action and Public Health Wales Partnership Agreement to you, which I think we're going to say that we're both really excited about. It's been a pleasure to meet Lindsay, who I'll be handing over to shortly. Many colleagues on both sides have been involved in getting us to this point, but as Claire said, I'd like to give special recognition to Johanna Davies, Head of Health and Social Care at WCVA, who has led the coordination work on behalf of WCVA, and I know that she really wants to be here today. It's a real shame that she can't be. So the purpose of today is to present the partnership agreement between the 2 organisations to you, and as Claire said, this formalises our long-standing relationship and sets out how we will work together more strategically across Wales. I know that it was recently presented to Bet, who had some really helpful comments, and today we are asking for the board's support for the ongoing development of this partnership. We're also asking you to note the draft action plan, which translates the agreement into practical activities and shared outcomes, which have been included in your papers for awareness. In terms of background, as Claire has already said, and I won't repeat, we've got a long-standing relationship and we delivered a real value for the communities across Wales. So what we're doing now is taking that strong foundation and formalising it so that we can work together more strategically, consistently and sustainably. As Claire mentioned, we've had 2 really high energy workshops, one hosted by WCVA, one by us, and they've been really key in supporting the development of this partnership and to bring us together, both organisations, to start to build those strong relationships. And the agreement sets out our shared aims, principles, roles and governance arrangements. And we really see ourselves as partners in prevention, with primary focus of our partnership on improving population health and reducing health inequalities. So at a very high level, the partnership vision is 4 key things: to strengthen public health and community wellbeing in Wales, to protect health, prevent harm and enable healthier generations. And both our organisations have unique and complementary strengths, as well as shared values and common goals to help us achieve this. And bringing these unique strengths together will strengthen our ability to deliver on this vision. In terms of long-term alpha-term outcomes, we want to build mutual trust, be really clear about our roles and responsibilities and how we're going to work together. We expect more proactive collaboration, with joint planning, shared priorities becoming the norm rather than the exception. We want to attract sustainable and increased investment into prevention and community-led initiatives to demonstrate the value of coordinating our approaches. And ultimately, we want the partnership to strengthen the evidence base for community-led prevention so that we can work together to influence policy, shape services and make better informed decisions. And these outcomes really reflect a shift from ad hoc collaboration to a more strategic long-term partnership. I don't expect you to be able to read all of this, but I very briefly wanted to touch on the action plan, which is grouped into 3 key themes, which are strengthening collaboration, things like shared presence at key events, reciprocal learning, route map for engagement with the voluntary sector. Also investing in prevention and community capacity. We've already started the work around the Lloyds Bank Foundation Community Capacity Initiative, but also things like Public Health Wales supporting the voluntary sector with evidence that will make their bids stronger. And then finally, building evidence for what works. So this is around continuing our programmes such as HAPA, Strategic Partnership, social prescribing and so on. And these are all supported by really clear long-term outcomes and we're really clear and we wanted to set out what good looks like in this space. We know that we need to develop short-term outcomes and we will be doing that collaboratively. So last slide from me, in terms of partnership maintenance, Jo Davis, I already mentioned, and myself will work together on the kind of coordination with the support of our leadership. We'll be guided by our shared action plan, recognising the difference between our organisations to make it meaningful. We'll meet regularly, but annually definitely as a partnership to discuss progress, and we will develop really clear ways to monitor and evaluate our partnership to ensure it's impactful. And so now it gives me great pleasure to pass to Lindsay.
Oh, diolch yn fawr iawn, Amy. Can I first just start off by saying I'm so excited about this, I can hardly breathe. And also to acknowledge the support of Tracy as well. So I've been in the role nearly 2 years. I have no idea where that's gone. But we had some very early discussions after my appointment about, well, what is our relationship? What is this thing? What could it be? What could it look like? And I'm just delighted to see this partnership agreement come to fruition. So thank you for your openness and your mentorship, actually, while I've been sort of bedding into these shoes. I have big ambitions for the voluntary and community sector. And one of the things that makes me really happy about the action plan is I don't see anywhere where it says the third sector, which implies third rate. And that's an image that I'm quite keen to drop. So voluntary and community sector, I think we've yet to come into our power, we've yet to take our place in Wales in terms of parity of esteem. I want to change the image of the voluntary community sector as the gap filler, because actually for years we've been before deliverer. We've been doing this side by side for a really, really long time. So I think this resets the relationship, this resets the footing, I think, particularly in our sector, which is
a hell of a lot smaller, has a lot less resource, but I think the agility and the creativity and the adaptability of communities that we can bring, there's so much potential to strengthen each other. So Tracy and I have had conversations, we've got 100 ideas. I'm going through the process of writing the next iteration of WCBA's strategy, and I'm trying to answer some real key questions, particularly in relation to what is the role of our sector in social cohesion, in terms of being the glue that holds everything together. I know that's a concern to colleagues at Public Health Wales. I'm also working on what is the role of the sector in national resilience, which is something else that we can collaborate on. I've actually called to Welsh Government to put on the national risk register for Wales, up there with pandemics and wars and everything else, the potential collapse of the voluntary community sector. Because if it did collapse, Wales would fall to pieces. Can you imagine if all the volunteers just said, nah, not today, that people would never go on strike because the stakes are too high, especially in your field, Kate. So I think figuring that out together would mean that we can minimise a whole load of risk, especially around safeguarding, future illnesses, all of those things. What I haven't got to grips with yet, and that is a priority for my new strategy, is where the communicative tentacles of our sector reach. So we manage a lot of voluntary community sector networks, we have a lot of key partners, and there's just massive communication power that is yet to be realised. I'm really interested in what that means for increasing vaccination rates, for instance, and things that are very much high on your agenda. There's also a new volunteering vision for Wales. So this was launched in the summer, and the new vision for volunteering, it's still sitting with Welsh Government. It hasn't quite yet come to life, it's kind of still in its infancy, but the vision is about tying volunteering to the national identity. In Wales, we step up, we help each other. I do think the answers to our problems are in our communities already. And Tracy and I have discussed the possibility of Public Health Wales being like a trailblazer, not just as an organisation, but as an employer, but for what that means. For how we set an example of what good looks like for volunteering. We know that there's nearly 1 million volunteers in Wales. I think there's so many more that don't even call it volunteering. People are just helping, good people just doing good things because it's the right thing to do. And there's a lot that we can do to strengthen each other in that space. I think we could share data. I could go on. I could talk a glass eye to sleep about this because there's so many different ways that we could maximise each other. But I know that you're quite keen to ask questions, so I'll wrap it up there and invite any questions or comments by you.
So yeah, thanks. We're going to have to leave in a few minutes, which is devastating. Just to say thanks to the teams, both organisations teams, but big thanks to you, Lindsay. You know, we really value the relationship with WCPA. We have for many years, and it's really great to see us, committing in writing what we're going to do together, and it's just as much as get to know each other better, and then committing to doing a few things, and then seeing how that relationship builds, and then it can become even more purposeful. So just conscious of time, just to say a really large job to you. And I know Claire, Amy, and the team at Jim put a lot of work into this, and really exciting to see how it works. And I'm sure the board, maybe in a 6 months' time, it'd be good to bring back a bit of a progress report as well. So just a really big thanks, and I'm really excited that we can really we try to put the tenterhooks into how we can connect with the magic happening locally. And so I high expectations that we can really do that with through your auspices and with colleagues across that voluntary sector. Thank you.
Yes, thank you. And I'm going to add my particular thanks as well, because I obviously worked with you in a slightly different capacity, and I know that volunteering superpower is alive and well in Wales. Yeah. And I absolutely agree with you that there's a reach that you can have that as a national organisation we can't have. So there is something about how we work together in the most effective way, but I think it's really, really exciting. I'm with you. And it's absolutely brilliant that you're able to come to our public board meeting as well, so that we can really demonstrate in public, what our commitment to each other is. I also hugely look forward to that kind of regular update about how we get our reach into our voluntary communities. I'm volunteers communities, I'm going to say, rather than our sector, but it's about how we connect with those individuals, and I think that's a really important thing. Now, what I'm going to do is, because Tracy and I have to go, is I'm going to pass over to Claire, our vice chair, and Claire will then field all of the questions from the board. But thank you so much for coming, and hopefully we won't be too long.
I just wanted to really welcome this piece of work. It's going to be, I think it's a central strategic importance to this organisation, really across the board, and all our different divisions. There's things that we can use for, not just for us kind of top down in a way to deliver our objectives, but also to learn, that bottom up learning about barriers. And especially, I sit on the board, sorry, I'm Tamsin Robertson, non-executive director with a hat on for equalities and diversity. So from that point of view, this piece of work is really important in terms of targeting certain communities, understanding communities, and, extending the reach of Public Health Wales in terms of, some of the difficulties that we might find right across the board. So yeah, it's great to see that well.
I'm called Dewey. If I do go like August, my opinion. So I'm the National Director for Health Protection and Screening Services, and I have oversight around our emergency response to health threats. And you'll have heard me talk about the importance of the community and voluntary sector in response. And what I'm really keen to understand from you, is there anything more we need to do and do to actually promulgate the importance of getting the sector into the discussions through planning? Because there's nothing worse than bringing people in who haven't got the established networks when we need them only in response, but actually the planning phase is critically important.
Question I've got the upper value on. There's a few things. I think the size and scale of this organisation is considerable, and if we can be around the table earlier at design board stage, what I find often is things are strategised and there's a flow chart of who's involved, and my sector's down here somewhere as like a bit of an afterthought, when actually we could do so much more if we were included earlier in the conversation. I think the other thing to really bear in mind is I have two people on this. So I have Joanna, who I wish I could clone, who leads all the health and social care networks, and I have somebody on the health force Cymru project. That's about volunteering across the health and social care sector. So I don't necessarily have any dedicated resource to make this fly. So I think that's something that we need to strategise on and look at where we bring resources in to make this really significant. Other than that, it's mobilising data. I mean, Tracy's very kindly offered to help us analyse some of the data we have. We are so data rich in the sector, but we just don't have the skills to analyse it and to interpret things. I'm also going to borrow one of your behaviour change specialists to join the steering group for the new volunteer vision, because we want to see a national behaviour change. That was a gap that was missing before, so it's already starting to come to fruition. But yeah, they're the main ones.
I feel good. Jimmy Ministry, cyffordd kind of like on the academic. I really welcome this. I think I just want to cite the board on a couple of things where already the voluntary sector have made a big difference. So you're probably sick of me banging on about the work that the diabetes voluntary sector has done, but they've helped us create a point of diagnosis pack written by patients and for patients, which we couldn't have done They've got reach for us into communities in terms of people living with diabetes. Emily will tell you that the voluntary sector are integral to the whole delivery of HAPAs, and we couldn't deliver it without them. I have a separate ambition, which is we don't have an ecology of self-care and self-management in Wales for most long-term conditions. We don't have it anywhere else in the UK either, so I'm not singling out Wales. But there are areas which are ahead in self-care and self-management. HIV is an obvious one. And that for me is one of the areas where the voluntary sector comes into its own and excels. And I think, well, I know for us, I've read the evidence, that if we got good self-management fund in Wales for everybody with a long-term condition, the NHS would be far more sustainable. And we cannot deliver that without the voluntary sector. And I do think that's something I really like to work on. I think the other thing for me is supporting the sector to build its public health skills, many of which it's already got. But, you know, having mentored people onto the register from a voluntary sector background, I would be keen to look at what more we could do in terms of how we get people included in that, what skills we can work, but also what skills come back to us, because you are better at many things than we are. So I think 20 years ago, when I was a much younger psychologist, the British Psychological Society had a year of giving psychology away. We went and talked to all of the voluntary organisations and went, well, if we don't like it, can we give it back? Because we took a deficit approach to the voluntary sector, which is the wrong thing to do. And I think we need to take an asset approach. So I think there's much that we can, there's much we're doing, there's much that we can work on, and there's quite a lot of stuff I'd like to do. And how we build together that kind of influence, not just across what you're already doing, but across the potential for self-care and the rich self-efficacy that comes from volunteering. Anyway, I've taken up enough.
Thank you. So, hi, Lindsay. Samina, as our National Director of Policy and International Health. I just wanted to say thank you for your policy advocacy work, because we've had good conversations and talked about our priorities, and there was a huge amount of alignment. So, following our conversations, we've been talking to Johanna. She's been fabulous, and I've learned a lot, and we've learned a lot. So I think this is a really helpful two-way collaboration for us. So I just want to say thank you.
Oh, likewise, we're learning a lot too. Yeah, it's really been eye-opening, just sharing each other's worlds, really.
I was sitting on my hands because I wanted to make sure that the colleagues I knew large myself. But before colleagues would have been surprised if I didn't say something. Sitting here. So yeah, Kate Young, non-exec director. Actually, my title, it says third sector. You're right. We're trying to remove that thing. So perhaps I'll see if I can change it to voluntary sector interest on the Public Health Wales board. I am so excited and pleased to see this, because colleagues will know who've been with me on the board for the last 4 years. I think there's not a meeting that goes by, where I'm not saying something about what are we doing with the voluntary sector and how can we strengthen this and what can we be doing. So to actually land to this place is brilliant. I think there's a really good point you make about capacity building across the organisations. I think there's also something about working smarter, because I think we actually have quite a lot of really good tools on both sides that perhaps maybe we haven't maximised. So as part of that mapping exercise, as much as identifying gaps, I think it's about what we already got that we can use to better effect. From a Public Health Wales board perspective, I think the question that Meg's raised, which is around how do we get people in the process earlier. I think some of the conversations that we talked about today in terms of our development sessions, for me, it would be lovely if once this partnership agreement is sort of now established, that it's almost like a golden thread. So it's a checkpoint. So when we are talking about doing things differently, or we potentially have a deep dive into a particular area, we are saying how does that connect in with our partnership agreement with WCVA and the wider community sector? Because I think that's how we will continually check against. And I absolutely would love it if when we have our annual check-in, when we have that, it would be lovely if we could actually have some members from the community of examples of some of the partnerships that have been involved. So I think that's really great. And our staff conference days, wouldn't it be lovely if actually, you know, there were some partnership examples there where community partners were there to demonstrate working along some of our fantastic teams in the community. So I think there's so much potential for it. It's taken us a while to get to this space, but I think it's a brilliant thing. But I wouldn't be biased.
It's just the right time. Yes, it's the right time.
Yeah. Any other questions? No, and then it just forced me to be more excited than anyone else. I feel the need to up the excitement. It's brilliant, and it's great to hear what's already happening. I think the data thing's brilliant because you're completely right. The third sector is awash with stuff that would be useful to all of us. So I think that's fantastic, and it's just lovely to have you here to what we're supposed to do, note it. That seems a bit lame, but to celebrate, I think, the agreement. So thank you so much, Lindsay, for coming, and Amy, and Emily, and of course Jim and Claire as well. So thank you for your time, and hopefully we'll see you again and hear about all the work at board level.
Thank you for the warm welcome. Yes. Yes. Yeah, I'll see you soon. Thank you. Bye.
It's great to have a breathe.
I know.
But they're still. Yeah, but you don't think my own kids are right.
I like the Welsh kids.
Right, so in the absence of the chief exec, we're skipping the chief exec report for now. We'll come back to it later on. So if I take you on now to 4.2, latest public health overview, and hand to Ian.
Yeah, Ian Bell, do we cover either Nichols data DBDO? Ian Bell, Director of Research Data and Digital. So I'm not going to focus so much on the dashboard this time because a few months ago we presented on healthy life expectancy, and we said we were at the start of a journey of analysing it, and the paperwork provided with it gives you an update on where we're at. The first thing I want to do is manage expectations. The idea we're going to get a perfect research study which directly proves the link between healthy life expectancy and waiting lists, I don't think is going to happen. That being said, the game we're in is triangulation. And I think what we're seeing is a lot of information coming together, which is of concern. I don't think yet it conclusively proves it, but equally there are two things that are true. One, Wales is seeing a steep and ongoing decline in healthy life expectancy, and that is steeper than that going on in other parts of the UK. It varies by local authority, but it is very concerning that that is going on. Also, that it is driven a lot by females and younger females in particular. Secondly, then I'm going to turn to waiting lists. And I think the bit for me, which is coming through strongly here, and the bit which I find probably most alarming, is the differential on the increase in waiting lists by age, and particularly for the 0 to 17-year-olds. And there's further work to be done there about what this means and what the impact is on the ongoing health of that group by having such long waits. Because when you look at it and in the charts, what you're seeing very carefully here is that actually the amount of very long waits is coming back down for the older age groups, but not so much for children and the younger age groups. Then the point where I'm only just really attuned to it, but the focus on very long waits may actually be being counterproductive. Because the most recent data is showing that while very long waits are down, the median wait is actually increasing across most health boards. And this is where I'm going to put the final bit of the jigsaw together, which is what is the impact of the waits. And we dug out examples from a well-respected peer-reviewed journal publication around cancer and the impact of weights. And what you could see from that is for every 4-week additional weight, you were getting an increased probability of mortality coming across this. And so what we've got to be doing here, I think where this takes me down a path up here is, we know from previous work that wider determinants and the cost of living is having an impact. This is not saying it's all about waiting lists, but what it's saying is that there is clearly an immediate issue which is impacting on very young people, particularly with long waits, and could well be affecting healthy life expectancy. And so I will stop there and leave open for questions. I think where I need to be taking this, and is really about that need to make sure that we strengthen the pillar around healthcare, public health, alongside the work on wider determinants and how we work with the system in order to do this, which of course is key from the accountability meeting. So I'll quit there and see what questions I have. So thank you very much there.
Nick?
Non-exec director. Yeah, I mean, really interested in the assessment there. I suppose there's 2 points. I mean, one, it slightly worries me about how we land the message and how we make sure we understand it properly. Because I think one of the risks to us moving to preventative health is the consistent, constant focus on waiting lists. And if we don't narrate this with the right subtlety, it will just drive more and more resource and focus away from prevention into waiting lists. And certainly, I reflect back on what you've just said. I think almost 20 years to when England were trying to manage their waiting list and started with this pale view of the world. And then they moved to understand as to what that was doing and the damage in the middle of the waiting list, and how they had to change the dimensions of how you had to concentrate more on where the health impact would come rather than just on the numbers at the end of the line. So I think there's probably some lessons from history, but I do think you're right, and what we probably need to get to something which provides a different evidence base of the risk is, which is going to reinforce the consistent drive to focus on waiting lists, which takes resource away from us getting into a more preventative mode. So even though that may be a recognised need and strategy, as long as that becomes a focal point, we'll always, certainly in my view, struggle to get a proper focus around preventative healthcare. So I suppose it's a bit of a, I appreciate the work and I totally recognise it, but I worry that if it goes out too bluntly, it will just reinforce a direction which is preventing us getting a proper focus on prevention across the nation rather than just through our lens sitting here in public health.
Right, so yes, I think I agree that it's really interesting work, and I think it's really fascinating, but I think there's a real danger if we only use waiting lists. I think that we need to make clear everybody understands we're using it as a marker, but we're not using it as anything else other than a marker because of all the need to triangulate. So I was really interested in thinking about there's so many things to triangulate. I can see why we do it because it's something we can get hold of. But actually looking at the socioeconomic conditions, the geopolitical situation, all those issues, much harder for us to play into anything we can lead the change with. So you did put in there something about a full evidence review, and I wondered if that could become a research priority, and whether we could raise that up in research agenda, not for ourselves necessarily, but in the work that we do within the research world, actually try to get full evidence review, although I suspect the evidence is going to be very hard to get hold of. But Samina's behavioural team, for example, might have some perspectives on this that might help us. But we should really make clear this is a marker, but it is very bad news for Wales that the rates of life expectancy are going down, particularly for women in Wales. And the question of then perhaps how in women's strategy we reflect this. What is it? What are the things we should be doing to make health for women in Wales better? What would make it better? And to try and come up with some of the narrative as well. Because I suspect however much research we do, we're not going to come up with anything that couldn't have holes picked in it. So I don't know what other people think. Want to come back here, Ian, or like you going?
I'm comfortable on that, so I think it's a very fine balance here. You can argue either way about whether we're over or under focus on healthcare, public health. I think the clear message, I take Nick's point of view of the world here, which is we've got to land this carefully and in a balanced way. Earlier work very showed equally some correlations with particularly cost of living impacts, and we need to draw that out as we land it. I think the second point on triangulation is there is a lot of triangulation being done around preventable mortality and some of the other indicators listed in the paper, all of which did led to me a bit of a thing. I think for me, the core thing which this has landed, both for myself and also potentially within Welsh Government, is the lack of focus on children's waiting lists. And therefore, I think if I was to take one thing away from this, is actually probably as much as your lesson from history, Nick, is also that need to focus on the children's waiting list as well, rather than anything else. So I think there is a message for the healthcare system there. The final bit I should have mentioned is a lot of this work has been shared closely with the CMO, who's really keen on it and working closely about how we land this in particular in order to do it. Yeah.
Excellent. Yeah, totally agreeing with Nick and Sian about the kind of wider determinants. I mean, the graphs on by health board and by local authority really demonstrate that it's more socioeconomically deprived areas that kind of bringing down the averages. And I think, I know this is a process, and it's really important to understand and kind of take each kind of factor and break it down, which clearly this is the first kind of element of the suite of things that might be causing this decline. But also I think we probably, like you just said, we need to have an eye on what's our response to this going to be, what's our suggested, or what are the recommendations. For example, you're saying the children's waiting list, but it's also, are we heading towards a situation where we're going to suggest that there needs to be an allocation of resources, targeted allocation of resources? I mean, would we go that far to say, are we looking at targeting resources to poorer areas? Because, you know, all this work will be interesting in terms of highlighting what the issues are, but are we going to be brave as a board in a response to it in a way? I know I might be putting the cart before the horse here, but I think it's, where are we heading with this kind of piece of work in a way?
Exactly. I think where I think we need to head here is our role is then to work within this, I think, is where the evidence review part becomes important, is what would the evidence suggest and lead us in order to do. And then I think there's two things. One, what would the evidence suggest we do about this? And then secondly, how would we implement and how would we recommend it? Because I think too often in Wales, we're good at following the evidence part and poor at following up in the implementation. So I would look to be, I don't think it's our job to do it. It's our job to work with the system to help them get to the right solutions in order to do it. And then for us to make sure that we provide the bits only we can. So that's where I'm looking at Selena around some of the wider determinants, where I'm looking at Jim as well on some of that. And also some of the national things we can take forward on things like Healthy Way, Healthy Wales, which may well help on some of this. So that's it. So Jim, I probably said what you would say there, but hopefully I didn't.
So I've got Selena next, then Jim.
You did find it.
Thank you. I think this is really, really interesting, and it really throws a light on the issue, because there's some new stuff in here that I haven't appreciated before, such as the impact on younger people. So that is absolutely something new that's come through. I absolutely agree that we need to look at the wider factors. So if we think about things affecting young people, you know, economic conditions, economic inactivity, mental health and well-being, they could all be playing a factor. I also agree, and there's been some conversation out of the meeting about further work that's happening, and I think it's absolutely vital we do that. So if we look at one of the slides, it does highlight the proportion of young people that are waiting a long time. But if you actually look at the numbers, the actual numbers are relatively low. So we just need to unpick that further. And I think the other thing is the planned work on primary care is also really important because that's where a lot of the interaction with the health and care system is. So I really welcome this, and I also welcome that further connection with Time to Talk Public Health. Really good opportunity to do that further triangulation. And I agree with colleagues about we need to shape the narrative here. You know, we've got data, but how do we use it?
Dale, thank you. So without repeating what Ian or Samina said, because I think they're right. I think this is exactly where we should be. I do think we have a challenge in the public health field in that we tend to over-describe to exquisite levels of detail rather than not deliver. And we can't, you know, the profession needs to move on. And the chief medical officer for another place once said, now, what matters, there's no such thing as a silver bullet in public health. There are multiple accumulations of things together create an area under the curve when you have to be persistent, insistent, and consistent about delivering work. You can see that was in my words, but and to my mind, this will be a basket of different interventions, some of which will be in the healthcare space, some of which will be in the prevention space, primary prevention space, some of which will be in the wider determinant space. I think the job we have to do is work out which is going to give us the most impact for which population in which area. And I think, yes, we will have to target it at some deprived communities because we know actually that the worst access is in communities that are at the sharp end. And I think we should be absolutely unapologetic about that. That we do have a life expectancy and a healthy life expectancy gradient in Wales, where the poorer you are, the more likely you are to be ill when you enter retirement, and the more of your retirement you're likely to spend in poorer preventable disability. And I think that's the space we have to be in. I think what helps from here is that I think we need to come to a settled view as an organisation about what are the things that will make the difference. Amass the evidence behind that of the impact they will have and actually advocate for that across the system so that we deliver those things that will make the most impact. I think we owe it to the people of Wales because I think they've got a right to healthy life expectancy. And I think this is a kind of system leadership moment for us. Sorry.
Yeah, I'll be able to repeat. So I think, I mean, the agenda item before this, we were just talking about WCDA collaboration and data and things, and actually conversations about what's happening with women, what's happening with younger people. There's a lot of data out there. So if we just take unpaid caring, for example, we are seeing more and more sandwich caring. Most of that is falling to women. That means a lot more women are missing medical appointments because they're not able to. That's one of the things that's behind the sort of new sort of women's medical, piece of work that the Welsh Government has just done. So, but there's a lot of evidence and information on that area that's sitting, for example, with organisations like Carers Trust and Carers Wales, and there's tons of data in that space, which Lindsay alluded to, didn't she? There's a lot of data-rich information. There are a lot of youth groups and community organisations that are working with young people in the communities that Jim's talking about. A big lot of evidence and data in that. So I absolutely agree with everything that's been said. I think when we are working out what makes the ultimate difference, and some of the points that you just alluded to, Jim, is in what is the lever of change. I suspect some of those lever of changes are already happening. So some of it will be about dialing up on some of that by understanding what's going on at that community level. So it's another example, isn't it, of how that collaboration can really bring richness to the space. But it's interesting. Definitely interesting.
It is. And do you want to come back on anything briefly?
I think it's for I welcome all the steers on that. I think I should be said as well is waiting lists in themselves not be a public health issue. that there was a lot of good public health evidence about how we weight and the impact on health outcomes. And that's where we need to make sure we get our bit around it and around it, that encourage the system to do their bit on some of the other aspects. The final part, I think that everybody is saying the same thing here, which is there is a danger, and we spend all our lifetime trying to triangulate the data, looking for a perfect match, which is frankly that we'll never get. I think we all know there is enough here to tell us we've got to go to action. And the point here is, how do we get to the evidence review and work with Samina and Jim in order to define what that basket of measures actually is, which I'll work with the two of them on, and how we bring that together back as a joint the future board.
Yes. Meg, can we turn to you next to give us an update? Current issue.
Oh, yes, okay, that's fine. So colleagues will be aware of the outbreak of meningococcal disease in Kent. That's managed by UK HSA. The latest update is that there were 20 confirmed cases with 2 probable cases. The impact has been resulting from potential exposure in the blood in Canterbury, mainly involving students from the University of. In terms of impact on Wales, we haven't had any linked cases, either confirmed, probable, or possible, of Welsh residents, but we are aware that there are students at the university who are resident in Wales, and in the coming holiday period, they may return. However, with the passage of time and with the lack of new cases coming through, we believe that the outbreak may be closing soon. But we're waiting for time to pass, so that typically 20 days after the last date of onset would be technically the time to close an outbreak, and we're reaching that period. From a Wales perspective, recognising that a cluster of this nature can arise in Wales, independent of the outbreak, we're using this opportunity to do a rapid assessment of the preparedness of the system in Wales to respond to such a cluster should it happen, and the ongoing discussions of the best mechanism to do that. So that's the update.
Got any questions? I know we discussed private board vote. No? Okay. So in that case, I think we can all say that we can take assurance from the feedbacks and comments around the dashboard, and separately to that, note that Ian has said he'll bring back to us the further iterations of the work he's doing. And also then to note the update provided about our public health matters. So thank you very much. Now, if I can pass over to Angela to bring the to bring another exec members to talk us through the highlights relevant to, I can't even read that, sorry. There, yeah, the key one. The IMTP, an integrated performance report.
Yeah, this is the integrated performance report to the IMTP winners.
Sorry, should have my glasses.
So, thank you, everyone. Angela Williams, Interim Exec Director of Ops and Finance. And this section of the agenda is dedicated to an update on the Performance and Insight report. There are 3 papers. So you will have the cover paper and the IPR, and there's also then a 13-page paper on the financial position as well. So if I draw your attention to the second document in your pack, and that's the one that we work through together to provide you with more information and assurance in terms of the actions being taken as well. So the first section of the report is dedicated to our governance and accountability section, and that the first part of that is on people governance. We have one in focus section on sickness and absence, that we pulled out some key insights, assurance and actions, and some more data on sickness and absence by directorate. That's on page 6 of the 55 pack that we're looking through. And if I turn to Rachel, just to see if there's any additional information you want to bring to the board's attention, Rachel, on the in focus section, or any of the other people governance indicators in the pack.
Thanks so much. Rachel Atwood, I'm Rachel Atwood, Deputy Director of People and OD. So in the last month or so, from the report date, February, we did see a drop in year sickness absence from 5.1 to 3.9%. However, the 12-month rolling average remains above target at 4.5%. I guess where we are is very much influenced by a high long-term absence rate, which accounts for 81%. And that reflects data published by the CIPD and elsewhere that demonstrates trends externally to us across the UK, and in fact identifies increasing sickness absence rates that are higher than ever. I also talks to the healthy life expectancy data, and I think it's fair to say that as we see trends in healthy life expectancy data continuing, we can expect to see the same in our own workforce, and it's something for us to think about in terms of how we align population-based health thinking in our own wellbeing measures, assistance, and public health wellness level. And we did a deep dive with the PodCom in January in sickness absence and gave the committee some assurance. And we also ignored it last year in terms of mental health support for our employees, but completely reasonable assurance and in fact substantial assurance to the board of governors. And I will close that round. Thank you, Victor.
Do any colleagues have any questions of that section, or we move to the next one? Okay, so the next part of the section 1 is on financial governance, where we've got the 3 key statutory targets for us, and there's a detailed paper in the pack supporting this information, and that provides you with an overview of the month 11 financial position. So we're on target to deliver our PSPP, that's our public sector payment policy, where we pay all of our non-NHS invoices within 30 days. From a revenue position, then our month 11 position was a slight underspend, and we are tracking that closely now as we try to land the plane on a postage stamp for year end. So lots of work ongoing around gearing up our year end timetable and tracking almost sort of, on a daily basis the purchase orders and the commitments that we've made, along with balancing a list of risks and opportunities as we try to deliver the position which we're on track to do. From a capital perspective, there's detailed updates on each of the schemes in the pack, and again, same level of really close scrutiny and monitoring. It's always sort of like hold your breath as we anticipate deliveries quite close to the year end deadline. But again, daily monitoring of that provides us with assurance that we're on track to deliver that as well. So I'll just pause at that point to see if there's any questions from the financial side. Today. No, okay. So next section, corporate and information governance. So Paul, this is mainly sort of within your area. So is there any highlights you want to provide colleagues? This has been on section page 9 of 55.
Diolch, Angela. Paul Vasey doing a scrimmage at the board, Paul Vasey, board sec. So yes, we have a summary here of the policies that we currently have running through our system. There's a more detailed paper on that later in the agenda, so I'll pause comments on that for now. And then the second item is our position on Welsh health circulars, which was discussed in quite some detail at the last audit committee on Monday. And there are some actions arising there around how we fully assess non-applicable WHCs as part of our process that we're reviewing. So other than that, open to any questions.
So next section, Claire, is on information governance. Is there anything you'd like to highlight to colleagues on the next couple of pages?
No, I don't think so. I think the charts of time now, which we've put in, show that where we put in more open control over response times for subject access and FOI, starting to really deliver that, which is good to see. What we are seeing, and we reported at the audit committee this week, is that some of our subject access requests are becoming far more complex with a lot of use of AI. So they're taking a lot more difficult review and complex responses really, and time for our team to oversee them. Many of them are associated with employment issues. I don't think we're alone in that. I was with colleagues earlier in the week and they were saying the same thing. It's also affected some of our concerns as well. And I think it's just how we manage that going forward. Data breaches, the only one to particularly reference there is the issue associated with the sexual health incident, which we talked about earlier. And in terms of incidents and complaints, pretty consistent. We have some vulnerability when we have very low rates in months, particularly around concerns that if we don't respond to one, we have very poor performance. So it's really important that we're absolutely all over that from a consistency perspective, and we're back up to 74%, just underneath the target, but generally we perform really well. And those responses are good because we don't see very many claims back from the ombudsman. So we've taken.
So we move on to section 2, which is our service delivery, and we'll turn our attention to health protection and screening services. There are 3 very detailed focus sections which provide updates on breast test Wales, bowel and DESU screening programmes. So we're starting on page 18 of the pack here. So I'll turn to Meng to see if there's any additional information you want to provide, Meng.
Well, thank you very much. So let's start with bowel cancer screening. Disappointingly, the achievement of the standard is in the January figures. And this is despite the escalation to health boards that took place last summer. And we have asked for copies of the improvement plans, of which we've received 4 from health boards, and pending 2 more in the next few days, following up on a non-response actively. The picture there that's emerging is that we know how many lists we need to get through the activity that we are modelling for each health board area. And we know the health boards aren't able to provide the capacity for a range of reasons, which the conversations we had with them in July, August were really helpful in bringing out. And we took away some plans for action within Public Health Wales that we could do, and we're implementing those plans actively. One of the things that we do want to improve is the capacity of endoscopists, and we also want to promote the workforce around clinical endoscopists, so that it's not just medical endoscopists undertaking this procedure. So the current position is that the average waiting time is 7 weeks and 3 days against a standard of 4 weeks, but the range is between 4 and 13 weeks. But what's encouraging is that the average waiting time for the specialist screening practitioner, which is within that 4-week period, is actually 11 days, which is within standard. So that's a good positive sign that a part of the pathway is improving. So we have established a screening colonoscopy improvement project, and there's a lot of enthusiasm around this nationwide program board that will help us identify workforce actions, and any other risks that are happening locally to be able to improve the number of lists around this. Once we've assessed the plans, when they're due in by the end of this month, we will be better placed to understanding what further actions are required. But at the end of the day, this is about demand and capacity matching. But we're watching this space very closely. And in the new financial year, we're putting in into our contracts with health boards who will be delivering these services, measures to recover costs for underactivity. I'll pause there if there are any questions on our cancer screen.
I mean, just pleased in one way to hear that you've had over, I think you said, recovery plans back. Was just ask question how much, if any, you can share about whether they actually do have a plan that does recover, and what kind of timeline would we be looking at for that broadly, or what range of timelines if they're vastly different? Are you able to share any of that from early insight?
So one health board, we are confident will be able to recover the standard in the short term. So within weeks. In fact, they managed to get below the 4-week standard, I think 3 weeks and 3 days. So that was really good. It's the sustainability that's the issue.
Yeah.
So another health board has made a commitment to address the short-term issues, but through insourcing, and we know that's not sustainable. So we're working with them to create a more sustainable structure. And then the other 2 health boards, I think we would be concerned that their plans are not going to get us the target in the short term.
Okay, that's helpful. Thank you.
And I just have a comment really on the screening section. It just shows how fragile lack of resilience. Because if you have one doctor off sick, all our indicators collapse. And it just makes me wonder if there's any sort of way in which that can be planned into the future, you know, some sort of extra capacity. Because it's very, very so dependent on people turning up. And that puts a strain on them.
It does. And, you know, I think that point relates most closely to breast test.
I think so, yes. But I just.
Where the establishment isn't established in a state where there is sufficient resilience in the system. So it depends on the entire workforce to be there to be able to run the clinics. And it takes one essential component not to be there for whatever reason, and hopefully unplanned reasons, that the assessment clinic that was available is no longer available. And some of these have peaks and troughs as well, that actually as part of the, if I move on then to Breast Test Wales, as part of the work we're doing, we've undertaken a comprehensive review of the programme, and we're putting in place a service improvement programme to make sure that we can make the most out of mutual aid, surge capacity. And one of the things that we are exploring is how the 3 regions work together as one to provide that surge. Now, you will see on page 246 of the pack that the top right graph actually demonstrates how that surge and working across regions helps us achieve that standard. So we've exceeded the 90% standard of women receiving normal results then within 2 weeks of the screening, which infers that the reading will have been completed within 2 weeks, which is the target. So I think we're doing really well. But where we're not doing so well is inviting women to an assessment clinic should there be an abnormality. So there's something more to do around these metrics, because 2 + 2 = 4. So if you achieve these, you're not going to achieve the 3 weeks assessment. So it's that forensic detail that we need to get into as part of the service improvement program that will give us assurance that there is some sustainability in the actions. But currently we are looking at how the establishment could be worked through much more effectively. But there will remain some fragility with unplanned absences, and that will come down to funding, because the establishment is really lean at the moment. And notwithstanding that, there's also shortages in the workforce in North Wales, where we are finding it difficult to recruit to key posts like radiologists. So I'll pause there for Breast Test Wales. Happy to take questions.
It's another general point, just to commend you for diversification and changing the sort of job title, increasing the skills amongst a wider group of people, which you've done within the bowel cancer. And I don't know if there's any way in which the breast cancer can look at different roles given the problems of recruitment.
I mean, it's really important we take that into account because the workforce is diversifying. And we take an example from what we've done in microbiology services, the use of a blended clinical team. And I think increasingly we do it by necessity, but also recognize that we need to consider patient safety aspects in, particularly this service, which is very much clinically led and driven. Now, it wouldn't be, difficult to imagine how physician associates, for instance, physician assistants, for instance, might feature as part of the multi-disciplinary team. And, this is one of the things that we're doing as part of the service screening improvement program to look at the workforce, and that mapping is on. And then finally, for Dezu, I'm pleased to say that there's a slight improvement in the coverage 12 months. So that is very heavily dependent on staffing as well. As we take the images, we do the grading, and we run most of the pathway up to the point of referral. And I think this relates to Rachel's update on the sickness absence rates. I think the team has done a lot to try and bring people back into work, particularly around long-term absences as well. But the reality with diabetic eye screening is that the number of people requiring and eligible for eye screening is increasing. And, we're looking to the Tackling Diabetes Together work program to reduce the prevalent pool so that we minimize the number of new people coming in, because the reality is that we want to prioritize newly diagnosed diabetics. So when we get a referral in for a newly diagnosed diabetic, we prioritize them over and above someone who's on an annual or a biannual screen. So that's why some of these metrics can be a bit volatile, but obviously working closely with Jim's team about how we can understand the importance of diabetic eye screening as part of our bundle of care for people.
Thank you. The only thing I was going to add to that is that what I'd like to do as an addition in this report going forward is for that in focus section to be probably less words and plotting the impact of those actions on the trajectory of improvement in the performance. So I think that's sort of what Meg and I need to pick up and work on with each of the screening improvement programs, so that we can see and track each of the impact of each of those actions, which I think was picking up on Nick's point as well. So I think that's probably something we need to do.
Really important, so that we can use that to monitor progress. I would urge a little bit of caution, however, that some of these actions, it's very difficult to predict the impact on outcomes. So I know that if you increase the number of assessment clinics for breast test wells, you will increase the activity, and therefore you will be able to plot what that impact will be. But other things are less tangible. So I think we just need to be realistic about how much we depend on that and hold ourselves to account for either achieving or not achieving, because there are some complexities around the other actions that we take.
So just to say that there will be different measures of impact, isn't it? The impact on the performance, there's the sustainability, and there's the quality. And across those dimensions, you should be able to map out the different aspects, because they're not all just about the bottom line, they're about the sustainability, as you mentioned earlier, and there'll always be some about quality.
Anything else, Meng, on the other parts of the HBSS updates?
So you will note from the microbiology, infection services and health protection, the indicators are really strong. The only one to draw out is the rejection rates in microbiology specimens. There's been a program of work to reduce the rejection rates because that's inefficient. And this is largely because people aren't filling the forms in properly, and we can't process them for patient safety reasons. And that's improved a little, but it's been hovering around the 5% rate for a while. So I think we will need to look at new ways of trying to decrease the number of rejected samples received.
Which, how, I don't even know if we can, if we look at any benchmarking of what other labs might experience in that same way.
Yeah, I
To
don't.
see whether that's actually an outlier, whether it's good, whether it's normal, or we don't know, we just no idea.
When we've discussed it in our DMT meetings and we talked about benchmarking, I think it's consistent with other labs. But if you like, I can give you more detail around it.
I mean, it would be useful, I think, at an appropriate point to have some more detail. Just going to say, although it might be a bit we're going to come up to later, I suppose one thing I did spot in the papers was the blood culture collection element. Is, although a slight improvement, still has a long way to go, and I don't know whether these have any relationship.
So there are two metrics there around blood culture. One is when it's received in the lab and then to the incubation and requiring that to be less than 4 hours, we're doing really, really well. So that's 99.7%. So over target. But where we're doing less well is where the sample is collected up to the point of, so there's a courier issue here about getting the sample to the lab. But once we receive it, we know we do really, really well. Some of the sample taking to the point of collection is out of our control. But I know the team are looking at, how to improve this, because we've got rapid testing labs in all our acute hospitals now. And that's mainly where the demand will come from. So there shouldn't be a significant delay. So the lab managers would be looking at how to streamline those processes on an ongoing basis. So that's why it's useful to have this indicator. But you will see that, the trends over the last 12 months has been fluctuating between 71% at its maximum to 69% currently. So the spark chart that you see is probably inflated, but it's
I really
roughly
say,
around 16%.
I mean, I absolutely take the point, and I recognise it's the bit before we get our hands on it. But it's about what we try and do to improve it, because I have seen this elsewhere in other systems, and you can have an impact on it. Wales may have a different impact on the geography and other things, but I do think it's one, it looks to me, depends what we think the impact is on patients, and that was that substantial number are coming to us, not being able to be used. And I just wonder whether we should do something more focused with our partners, because obviously before we get our hands on it, but in order to take a focus that drives it up, I have seen substantial improvement elsewhere when a focus is put on it, and other places where they accept that's just the way the system works.
So the reality behind this is we need to understand the clinical impact. Yes, so technically a blood culture, you would want a result as soon as possible, because that would then determine what antibiotics you prescribe. Having gone through the process last night of asking the labs, what would you do if it pings in the middle of the night and we find a positive blood culture? The reality is that you might want to ring the wall, but actually there's no one there to take action. So realistically, it waits till the next morning. So some of this has to be put in the context of, well, is it going to make a difference if it's, 10 minutes late or an hour late? So I think we need to kind of be a little bit measured by that. But I'll go back to the question about asking what we've done to accelerate that process.
Just say, I recognise your point, but I assume someone thought of that when they set a target at 95%.
Well, that's
I'll just leave it there. But I do agree it's about what the priority.
Thank you. The other elements of this section, we've got updates from RDD, Policy International Health and Health and Wellbeing, which take us then through to section 3. So I'll just pause to ask if Selina Ian or Jim would really into their sections of this.
I wouldn't mind if that's all right, just, I will be quick, I promise, because I'm very conscious of time, but just to show you that you can see that the performance on smoking cessation continues to ramp up in terms of numbers, and our recent campaign has an effect. We're actually exceeding the target for calling people within 2 days. It's 94%, not 90%. So I think that's going up, and the team continue to kind of smash that out of the park. An important thing to note is that 100% of secondary schools are now action planning on mental health, and 96% of all schools are action planning, and the Cabinet Secretary is happy that primary schools are, in a way, they'll have closer relationships. So she's happy with that. We had the steering group meeting that she chaired recently, but we continue to work on this. Obviously, things like National Exercise Referral Scheme and some of the other programmes come in other work updates, but we continue to focus on this because we do know that smoking is one of the biggest early killers and one of the biggest causes of child poverty. So this intervention for people who quit, and you can see we're actually consistently well above the target 35% quit rate. We perform better than other systems in the UK. And actually, in terms of our quit outcomes, it's important to note that they are equitable across all population groups, ethnicity, sexuality, gender. So we do really well in Wales on this. And I think one of the things we have to do, given this morning's conversation, is there are some bread and butter programmes that we need to consider carefully within the work that Ian's getting us to do. Are these delivering lots for us? Do we keep going with them? What do we do? And I think smoking for me is one of the ones that's on the way to that. I think we do need to look constantly at that, but that's, I think, where we are. Apologies for taking much time.
Yeah. So moving on to section 3, strategy delivery. We've got an overview of the overall plan delivery, and then there's a slide on each of the strategic priorities. The current trajectory is that we would deliver 84% of our milestones by year end. That's 84% of our milestones that we set in April. So I just want to make that point. So it's almost, we don't add any new work onto that. So I just want to bring that into the context. So there's probably, 84%, 60% gap. There's probably like another 30% that's been added in. So I just wanted to, something that Nathan and I have talked about is how do we build the additional work? Because we don't tend to capture that, which potentially, the bandwidth thing as we move through the year as well. So just to highlight that to the board. There's also an update in this section on the strategic change programmes, and to highlight that 2 of those programmes are tracking now amber red. Just pause at that point to see if anybody's got any questions. You've got one. That's it. Right.
Is this on 3? Because I was just
Section 3.
yeah, just the inequalities. So just was interested in the drug-related deaths box. I'm not sure why why that was chosen. I mean, it's interesting information, but why are these kind of highlighted? These specific?
And Serena, do you want to do?
Yeah. So it's a mixture. So so basically, Jim, let you come in as well. This is pulled together by one of Ian's team who sort of works across the organisation. She does a fabulous job, and what she's doing is working with teams across the organisation to really dig into inequalities aspects of data. So that's what she's doing here. She's highlighting where things have come to light. Jim, I don't know if you wanted to come in.
I think he wants to come in first, but
I must say, I think more than that, what tends to be in there is the latest new information. It's really what we're trying to do rather than pick up anything. I think there is a point for going forward about how we iterbed the inequalities reporting more systematically into some of the other outcome and other measurements, but that we keep that up in the next iteration of development of the measurement system.
Thanks.
And the only thing I would add to that is that, of course, we've got a system-wide jobs needs assessment in the pipeline, which we've discussed with Welsh Government colleagues. And that is really all good things. So we've actively gone looking for these so that we can begin to address them. But there is a significant amount of work that it's doing in this wider system.
And then on to the last section, Ian, was there anything else you wanted to add, given the conversation we had earlier on the section?
I don't think there's much. The only bit I might add, actually, if I may, is very quickly, is actually on the front page bit. It's actually of the outcome right across the healthy behaviours. And given we keep on talking about actually what is our impact now, at this point, yet to take through all the evaluation work, which will come onto the IMDP. But I don't think we should lose sight that most of the healthy behaviour work is moving in the right direction on these indicators.
So it feels good to see the oral health improved status of children's mental health. Yeah, that's a good result.
Yeah, I'm very proud of my team.
They're very good.
Out of curiosity, prevalence of hypertension is going up. That's because they're rare. But sometimes things like this, it's good to be able to detect hypertension. So it's a difficult one to interpret for me. But do we have a view of what we are expecting?
Yeah, I can answer that because, as you know, we've got a national quality improvement standard on hypertension, and we did some impact modelling so that if we get every single person with hypertension well managed, we will save over 4 years 1,000 heart attacks and strokes. That's several hundred deaths. Sorry, I forgot the exact number. And that will be £15 million to the NHS. So we want everybody with unregulated hypertension regulated well. In a way, it's good for hypertension to be going up because it means people are at least case finding, and we've got the registers going because of the quality improvement register. What we now want to see next year is that hypertension being really well managed. And I think this goes back to the conversation on health inequality. Actually, there are some things you can do in healthcare, public health that will save lives and will make a difference and can be done within 3 months. And if the system puts its mind to it. So for me, that's this is one of the things I'm really kind of egging on. Let's get this managed, because if you manage hypertension, strokes, heart attacks, other cardiovascular events, a variety of other things, inflammation, a whole range of other things, then begin to become easier to manage and reduce. And it's a biggie. It's like diabetes is a biggie for all sorts of reasons. Oral health in older people is a biggie for all sorts of reasons. This is a biggie for multiple reasons for us. Sorry, apologies for being so quiet about that.
Thanks everyone, thanks Chair, that's the end of the IPR form and collection.
So if we can ask the board to consider the IPR, and I think we've all agreed that we can take assurance from the update that we've just had. Lovely, which leaves me probably to hand over to Pippa, Ray, whatever you're going to do.
Thanks very much, Claire. And we will take a break for lunch at this point, if that's okay with everybody. And we will come back at what time? 4. Okay, that's great. Lovely. Thank you very much. And enjoy your lunch, everybody. To the board meeting this afternoon. It's nice to see you all back and after a short break. I'm going to move straight on now to the Chief Executive's report. So Tracy, if you could take us through that.
Diolch Pippa, Penardal Howe, Tracy Pippa Edwy, Chief Executive. Quite an eclectic report. So I'm just going to highlight a number of areas. I'm going to bring some colleagues in just to elaborate on some, if that's okay. So we had the public accountability meeting, which were meetings that have arisen as a result of the Ministerial Advisory Group before last. So that meeting took place at the end of February with members of the board. So we had 10 members, mixing of executive and non-executives, and outlined the agenda. So it was a comprehensive meeting with the Cabinet Secretary covering a number of areas. And we have received a follow-up letter from that, and so we can engage with a couple of further actions just to pass some additional assurance with them. Second point is we had a really good meeting with the Deputy First Minister and Cabinet Secretary for Climate Change and Rural Affairs with yourself, Pippa, and Samina. So I'm sure if there's anything that you wanted to add, but very engaged and very focused around how we can support from a public health perspective. I don't know if you, is there anything to add? And then the third item, I'm just going to hand over to Samina, but before I do, just on item 3, just to mark a really important third time redesignation as a WHO collaboration centre on investment for health and wellbeing. So it's not an automatic process to be redesignated. So just to say huge thanks to Samina for your leadership, but obviously all the team, really important for us. But I don't know if there's anything that you wanted to say, and perhaps if you're on, there's an item later in the agenda as well that you may want to pick up that we.
Thank you, Tracy. So indeed, this is our second redesignation, the first being in 2018. It takes us to 2030, and it does show the value that WHO holds our work in. So I think that's fantastic, and it also is valued by Welsh Government. So this redesignation enables us to take forward some of the work that's been agreed between Welsh Government and WHO Europe as part of an MOU. We do have a webinar this afternoon, so I have messaged everybody in your call. Wonderful if you can participate. It's an hour long. We have a message from the Cabinet Secretary for Health and Social Care. The Chief Medical Officer is attending. We have participation from the WHO, and Tracy and Pippa, thank you very much for adding and to the event. And I think the key thing for me is that the work we do is for the people of Wales. It sounds grand, it sounds like it's all over there, but actually we always bring it back to Wales. So that's the key message from me. The other thing to highlight is that we have just launched our WEED team, so that's the Wellbeing Economics and Value team. And we have done that through consolidating existing resources. So this is about bringing robust economic insights in terms of strengthening our work on investing in prevention, public health. And we held a webinar to just sort of raise the profile of the team and the work and reach out to people and say, look, we're here as part of the system to support and enable future collaboration. We're really lucky again to be joined by WHO. And from Welsh Government, we had participation from the Chief Economist as well as colleagues from the NHS.
Thank you very much, Samina. So then drawing my attention to item 4, Claire, and are you keen to just...
Yeah, I'm just delighted to share with you that the first cohort of the, we call it Empowering Midwives to Lead with Compassion and Excellence programme was completed. So we had senior nurses across the organisation. It's the first cohort that we've ever done. We did it in partnership with the Royal College of Nursing. We celebrated the end of the programme, which was a 10-day programme across 6 months, back in end of February. You'll see some of the posters out there in the foyer. So it's, really good to see some of the quality of the work that some of the senior leaders are doing. Really well evaluated. Really feel that they've been invested in. And it's the first time that the RPN have run a programme which has been acknowledged level 7 accredited. So they're just going through their final submission of their assignments. But I think if you see the work they've done out there, it's something that we should all be proud of. Particular thanks to Louise and Angela and my team for grabbing this and running it for their day job. But also thanks to my colleagues who are leasing people across the organisation, because we've got a massive nursing and midwifery workforce, but we do need to invest in people. So really pleased, and if anyone wants any more details, I'm happy to tell you all about it.
Thank you, Claire. And then 2 more items just to highlight. The next one is item 11, which is changes to the executive team. I'm going to embarrass Angela momentarily, and I know, Pippa, you said at the beginning that you were going to say some words at the end, but just to flag that this is Angela's last board meeting. I don't want to steal Miss Thunder from thanking her, but just to say a massive thanks, Ange, not only for everything that you've done for Public Health Wales, but for obviously your 38 years at the NHS, but particularly in the last 14 months, you've been sat around the board table and execs, and you've been a really valued member of the team, and your contributions have been amazing. So just a really big thanks to you as you finish and you retire at the end of March, and then you're back 2 days later. Yay! For 3 days a week in April, we really, really appreciate that. So just to say a massive thank you, and I know Pippa's going to follow up on that, and we've got ample time to thank you again over the next number of weeks. But also just to note a big thanks to Neil Stooley, who is going to be acting director of finance, part of your portfolio for the 2 days that you won't be working in April, and then until Zoe starts in 13th and 14th of May, and we'll obviously have an opportunity to welcome Zoe. And then the final point was just about an update on the UK public inquiry. I'm just going to hand over to Paul and May just to do a short update.
Thank you, Tracy. Yes, so the Module 3 report was released on the 19th of March. We were not a core participant in this report related to the impact of the pandemic on healthcare systems. We did give significant evidence to the inquiry in this module, both written and oral evidence. Meg attended the hearing in London to give its account. So the report has 10 recommendations in it. They are really government-focused, system-based recommendations, but do have a significant relevance to us as a public health organisation in Wales, particularly in the context of the IP&C cell and how that can be strengthened to improve decision-making and governance. But as the process always is with these reports, we pass them into Meg's team in health protection and screening services, the reports to be scrutinised, the recommendations to be looked at forensically, and for us to then decide as an organisation how we respond. I'll hand over to Meg just to give a highlight of those recommendations to you. But I will flag that coming back to board in May will be a more in-depth roundup of where we are with the inquiry. By that time, we'll also have Module 4 report in on vaccine therapeutics. That's being published on the 16th of April. And we'll have a more rounded view of where we're at. So I'll hand to Meg.
Diolch, Paul. So there are 3 key themes arising from the 10 recommendations, one around infrastructure. So this is about the critical care capacity, digital systems that we have in place. There's also a focus on workforce, particularly around the support of the workforce and surge capacity. And these are relevant to us as an organisation as well. And then lastly, critically, is around guidance. And we oversee the healthcare associated infections and also our antimicrobial resistance from the HEART programme. And one of the things that we do liaise with our counterparts in other parts of the UK is to produce the infection control and infectious diseases manual. So this is something that particularly in relation to recommendation 1, we'll be working very closely to consider our options, because that's specifically mentioned around Public Health Wales's continuing role. So as Paul says, we will be putting a detailed summary of how this might impact on Public Health Wales, but recognising that these recommendations are for Welsh.
Thank you. Are there any questions for Tracy or her report? It's always amazing to me every time we have chief exec reports to see the breadth of work that goes across the organisation.
A lot doesn't get in the report.
So very huge thank you for that. We can move on to the next item on the agenda, which is going to be the sexual health test and post service incident. Then I wonder if you could take us through some of the
Yeah, so board will be aware of the sexual health test and post service incident that came right in November. And it raised concerns around how we were handling safeguarding information that was shared with us as part of the collection of information from requesters. There also arose some concerns around information management and information governance and the sharing of data. And the report details these elements that we've been dealing with. And just to update that we've taken the opportunity to recognise this as an enhanced incident and revise the governance of this accordingly. Now, we don't normally use that approach for internal incidents of this nature as part of our emergency response plan, but the governance arrangements help us manage the scale of this incident because of the significant numbers that we have to take a look back at. And also to say that Claire's team has been overseeing the look back around the safeguarding information. And as part of that process, we are validating with the health boards any actions that have been taken by the health boards when we referred safeguarding concerns to them. And that process is underway. We are looking to complete this by the 18th of April, and our assessment of that is we are scheduled to deliver to that date. In terms of the other elements of the governance arrangement, we recognise that it's really important that we continue to deliver a better service. We've also committed to undertaking an independent external review, and that will begin in April, and we're starting to identify people to join the review panel for that. Alongside that, we recognise that we need to identify what best practice looks like. So we've set up a best practice advisory group, drawing from experts across the system to define what good looks like in the service in the medium to long term. In the meantime, we recognise that there's some immediate actions we need to take for the current service, transitioning into the excellent delivery model. So a sexual health improvement group has been stood up under the chairmanship of Ian Bell and Claire Birchall to ensure that the team that's currently delivering the service are part of the solutions for making sure that the transitional arrangements are safe and robust. So I'm happy to stop there and take any questions.
Are there any questions from Meg on the actions that you've taken? Okay, thank you very much for that update, Meg. I think the board can take assurance that we've identified the issue, and lots of action is being taken, and it's proportionate as well. And I think the other thing I would say is, we have had an opportunity to discuss this in more detail as well already. So I'm looking at nods around the table, so we'll take assurance from the report and the update. Thank you very much for that. The next item on the agenda is the committees of the board report. So this is the report that sets out the work of the committees since the last board meeting in January. All committees have met, and the summary is in the report. There is no written update from the audit committee because that was just held on Monday, so it's been quite a tight turnaround. And I don't know, Kate, if there's anything that you want to raise from the meeting on Monday. Not. Okay, that's fine. Thank you. And are there any of the other committee chairs, Sian?
Thanks. Yes, and just to add a comment that we did look particularly at AI, and we want to raise which is, as you mentioned, and we would like to recommend that we do some more work with the board on AI because it's a rapidly evolving field. And as Nick says, we need reassurance as well as assurance on how AI is being used in the organisation, but also its impact on our work and how we might be using it, say, public health, messaging, etc. So just to raise that.
Thank you very much, Sian, and I think it's a really good point. It is a very changing environment, and I think there's probably boardrooms up and down the country that are having similar conversations, but it is something about how can we use it for good. And I think a more detailed in-depth discussion, probably with the whole board rather than just within your committee, would be really helpful. So thank you for that. Tamsin, was there anything from the people in OD? Okay, thank you. And Claire, anything from you? No. Okay, thank you very much. Then, is there any questions at all from anybody on the reports from the committees? So we can be assured that committees are doing the work that we have them to do. Thank you very much. Paul, I'm going to take the next item I'm going to pass to you, which is the annual review of corporate policies, please.
Thank you, Chair. So the report before us today is here for assurance that the management of corporate policies and procedures and other control documents is being properly handled in the organisation. So each of the committees receives assurance on policies relevant to its work area on a quarterly basis. So this report brings it all to one place to give board extra assurance around what we do. I should add in that this year we have had an internal audit on the way we manage our corporate policies, which gave us a substantial assurance. It was a really good result. The report itself sets out that we have 166 policies, control documents and procedures in place. Out of the 166, it outlines that 118 are in date, 48 are falling out of date and need renewing, and of the 48, 13 of those are all Wales policies, and 35 of those are Public Health Wales policies. Whilst they are out of date, it doesn't mean they're out of operation, they are still in place and working. And we work with the exec leads on each of those policies to ensure that they're risk assessed. And if there's a need to update anything urgently, they are prioritised and updated. The report sets out in detail what the status is for those 35 and when they will come to a point of being in date. And I should point out there is a slight error on page 10. The joint working framework policy will be coming to the board in July 26, not May 25. Thanks to Selina for flagging that to me in advance. So happy to take any questions on corporate policies.
Portal, Nick.
So just I mean, I should probably give you notice of this one. Do we have any sense for how long the longest out of date one has been out of date for? Does that make sense?
Does make sense. I don't have that information at my fingertips, but I think Nick, it would be a good one to bring to audit. Yeah, just to have that oversight of management. It varies across the piece. From memory, there are some that have slipped for a while, but we still do risk assess them. They usually slip either because it's contingent on a change or an activity somewhere else, or because there's a procedural change that we're planning which impacts upon it, so that we don't change it once, then change it quickly again. But happy to remit that through to
So I think useful to have that view. I think the sense is we were getting very close on top of it, and it's so that my hope is they're not that far out. But as you say, there may be for good reason, which would be a useful indicator, I think.
Yeah, I think that would be a very helpful thing to have. I'm sure we can take that forward. So thank you, Nick, for raising that. Any questions at all for Paul? No, thank you, Paul. I think it's been really helpful actually to have this book to board, so that we can actually with assurance and the fact that we've got policies that we are keeping them up to date, or if we're not, we won't on. So thank you very much. I'm now going to hand over to Angela for the annual review of estates. Thank you, Angela. There's something the board asking for, please.
Thank you, Chair. So this paper, we talked about it in the board just before Christmas time. So we've pulled together this to give a high level overview of the configuration of our estate, which includes sites which we don't manage as well. And hopefully then it gives you an overview. I think that was the request, it sort of gives a really detailed overview of the estate, along with the condition of the estate as well. So just bringing that to you for information today, and hopefully for you to take assurance on the management of our estate as well.
Thank you. Anybody got any questions?
It's more of a comment. I found it really useful to see the whole estate, because I didn't have any idea of some of these buildings. It's a great starting point to understand what we have and the condition, but I think can we use it as well to kind of prioritise so where we need to kind of improve, because clearly there's some areas which are quite in need.
Definitely. Yeah, it is something, and obviously Clive, builds the work that you did previously into the opposites as well. So it's just, we'll build on this. And also one of our milestones for 26-27 is our spatial strategy. So it's going to help us with taking that forward as well.
Can you give us a couple more words on spatial strategy?
How many more words?
So what?
Yeah, so I think it's wider than just an estate strategy for us. So it's about sort of looking and working with other organisations and other partners to see how we can utilise the whole of our Welsh estate, I suppose, from a public sector perspective as well, and obviously from a closely working with Meng and the screening colleagues as well to see what access we can have to access other buildings that will be of use. And it's something that Tracy's quite keen for us to.
Yeah, because estates tend to be fixed buildings, whereas we want to look at many assets. What are the settings that we want to be in the future? What do those look like? That includes our ambulatory settings as well. So for us, it's more about space than it is a building. So that and if we underpin that around climate change, biodiversity, sustainability, circular economy, there's some real opportunities there.
Yeah, so really interested in working alongside Anna. We do work really closely with its colleagues and areas where we've got services. So there is something around the state of the building in terms of how we can clean and then the stance of the cleanliness. But there also is a real importance around accessibility, parking, because we know that impacts on people's willingness to turn up and participate, but also access. Have we got doorbells up here in terms of wheelchair access? So there's loads of stuff that we need to do in this space. We need to do it all in one place so that we're joining it up.
Yeah, no, that's really helpful.
On that note, I did notice there was no parking in Breasthurst for vehicles. So this is our only Cardiff screening centre.
Yeah, and we've got the mobile facilities where we tend to place them where there's good parking around accessibility, but then that limits us in terms of bus routes. So supermarket car parks, particularly those that are out of town, there's a problem then with bus routes. We also are aware that for some of our premises that aren't acute hospitals, we then have limitations in terms of the ambulance contract that we have. So if they're primary care settings or they're not acute hospitals, patient transport is limited. But certainly Breasthurst Wales in Cardiff is very limited. We've got facilities, obviously in Spire Gardens, but that's a bit of a trek. People have got mobility issues or will find it a bit difficult to pay to travel to those environments. So there's more work to do.
Yeah, just 2 points. So we're sitting in a building that we moved in 2016, and we conflated 17 pre-existing premises on whole in the area to do this because I'm back to the kind of common footprint and collaborative working, etc. And we've in April we're in North Wales opening a new combining of some of our screening services, etc. So we've been doing it. I'm really keen, but just to make the point that where we co-locate our labs, we have struggles in some of the health and safety or the build element because they're in the control of another organisation. So that's always a bit of a challenge for us. So we're not in full control of our estates. I'll use that word.
Ben, did you? Okay, that's fine.
But there's one more thing. There is then the added complication around some of our areas where we commission services. So, for example, one of our house boards is having a real challenge in terms of the infrastructure and the decontamination unit in endoscopy. So, where we send our bowel screening patients, then we have a responsibility to make sure that those services are meeting the required spec, so that can be dirty and clean rooms. So that's an additional area that we try and keep our eyes on.
I think I have to say, I think it's really helpful to have all of this put into one place so that just the same as Tamsin says, that you can actually see what the buildings are, you can understand how many staff are based there and what purpose they serve. And we are going to be having a board development session on how we manage that in a more strategic way. I think if I was just looking at these papers without any prior knowledge, some of the questions I'd be asking about things like my mileage, for example, that is poor quality premises, very few staff, costs quite a lot of money. And so I think, the opportunity to interrogate what we're doing with that site, whether we should be based there, whether we should be in the Breasthurst Wales Cardiff office because of accessibility, all of those things. I think it's really, really important to. It's important to us and our staff, but also it's important to all of the public who are going there. And as a wheelchair user, often I can't reach the doorbell, and so it's a subject very close to my heart. So I think I would say this paper actually opens up an awful lot of questions, but gives us a really great starting point. So that would be my kind of comment on this. So thank you actually for bringing it all together, and thank you for including all of the photographs because I think they really bring it to life. So are there any more questions on this? No, I think we can take assurance then that we know what our estates look like and how they're being managed, and I think that's really important. But moving forward with our spatial strategy is going to be really, really important. So thank you very much, everybody, for that. We've got some for approval. We're moving on now to strategic risks. So Claire, I'm going to come to you.
That's fine, Fred. I think it's because we're out of time on the agenda. So you've got the usual paper pack in front of you today. So the cover paper, which includes the diagram, which we know a number of you find really helpful. The risk at glance paper, which is used since the last couple of boards, and then strategic risk 1 to 5, strategic risk 6 is taken in private board. It is the position as of the 1st of February. And just for colleagues to know, the risk management development plan has transitioned to a risk management maturity plan, which we saw at audit the other day and was well received. So it's about embedding all of the good work that we've done so far and making sure that we take this piece of work really to where it needs to be to support our long-term vision delivery. It's probably important just to note that we did have a detailed discussion around whether we needed a new strategic risk around finance. We had a long conversation around that and went full circle again, in fact, a couple of weeks ago, where we agreed actually it's probably a bigger part of strategic risk too, in terms of broader capacity, capability and skill to be able to deliver what we need to do. Although there is definitely a corporate risk around some of the challenges which I know Tracy just referenced the chief executive. We will also, as part of the IMTP, hopefully approval today, reflect some additional actions and risks within strategic risk 5 around business change, capacity and capability. So in summary, risks 1, 2, 4 and 5 are within appetite and strategic risk 3 isn't at present. We have got the usual corporate risk register links in, and the sexual health corporate risk will be on for the next iteration seen by the board. So I'm very briefly just going to go around each of the strategic risks and to each of the owners to see whether there's anything else to add. So in terms of strategic risk 1, which is gyms, currently is at 9, the target 6 within open appetite. And Jim's team have noted there, obviously, the healthy life expectancy discussion that we had earlier on into the duration of the data. He also referenced the advocacy work that's being led in this patch, the work with CMO around the prevention advisory group, the tactical approach that his team has taken with our colleagues in the system, best use of evidence, best use of our system leadership, and how we bring the route maps to life. The really good work to see on the public health practitioner workforce, which we talked about earlier on in terms of strengthening and breadthening opportunities around the multidisciplinary workforce. And some really good work happening in the primary care arena around the cluster peer group work. Jim, was there anything you wanted to add?
I think you covered it extremely well. Yeah, I'm speechless.
Does anybody want to come in on strategic risk 1 now, or shall I leave it till the end?
We'll take them each in turn just in case anybody has any questions. Anybody?
Okay. Strategic risk 2, which is Neil and Rachel's current score of 9, target 6, and a willing appetite, which is sitting within at the moment. The exec update references the work that's been done around the strategic planning, the deep dive which Rachel mentioned earlier on around management and support of our staff who have sickness, particularly associated with mental health issues, and that was looking at CODCOM. Very clear around what our IMTP commitments are, including 4 to 4 finalisation of the people strategy implementation. And there is just one change in there around the performance management framework work, which just needs to push back into this time frame. Anything else from you, Rachel? Obviously, next time we will bring in the additional risks that we talked about with the many. Strategic risk 3, currently sitting outside of tolerance with a score of 16. The ongoing issues remain around sexual health, environmental, on-call screening, and the new information that we have around the PHW review, but really clear action and approach in there in terms of our response to those areas of risk. There's a new action point in there around the incident management approach to sexual health, which mentioned earlier. The transformation work is to be starting in HPSS, but ongoing concerns still around the resilience in some of the workforce areas, particularly in the north. And obviously, key priority in men's patch at the moment is the learning from exercise Pegasus, which we know there'll be more for us to do around. Naomi, is there anything you wanted to add?
Just one small update, which is to say that the environmental health protection out of hours service has been provided by UKHSA, and it was due to end at the end of March. Now, because of the need to kind of adopt a wider approach to health protection, there needs to be some lead in time to make those changes. We've been able to negotiate a 3-month extension with UKHSA to cover us until the end of June. So during that time, I've asked the team to accelerate the work and thinking about how we will then cover the out of hours arrangements beyond. Good.
You clearly some main conscious we've had a lot of things on the agenda today, so they've been given for sure it's very active. Strategic risk 4 is climate, which Samina and the team lead currently on a score of 8 with a target of 6 and within open appetite. I think this risk is really gathering some maturity now, particularly in terms of the climate change programme board and its alignment to the route map. There's a better understanding of climate threats due to the work being done with the Health Research Network. And obviously there's a real link to our corporate risk around the carbon footprint commitment. You wanted to add something?
Just very briefly to make the link for the climate response plan, which is also on the agenda, because that gives them decarbonisation and adaptation right. So it goes hand in hand with us.
Yes, just to so we have previously discussed as a board, looking at the global risks and the projected shift more towards biodiversity, decarbonisation, food systems over the next 2 to 10 years. So when we have had discussions with execs, I don't think we are, we rephrase it, we are going to have to revisit the alignment of resources to our climate change strategic priority over the next number of years. I think that's going to be really key, because we need to be thinking about that down the line. So just to make that point, so just reinforces why it's important for us to have a risk here. Really.
Any questions? And then finally, last but not least, is strategic risk 5, current score of 16 with a target of 6. Still complex for us to manage and still a stretch in terms of digital capacity and the size of the challenge, particularly in terms of what's outlined in the IMTP. And we do need a lot more maturity in terms of our business change. Also complicated by the scale of technical expertise that's required in this area, and there is some reliance on both agency but also our colleagues in DHCW, which is we know is vulnerable at times. However, the DARC and AIDA are maturing, so we have really made some progress there in terms of them linking to both our operational agenda but also our IMTP. And just to note the temporary support to support the gambling arms work. But Ian, anything else you wanted to add?
Yeah, I think I summarise it clearly, because I think it comes on in the IMTP. It's actually which are real danger here that we focus on digital data. And digital data is an enabler of a wider change. And without that focus on wider change, there is a big risk, I could be quite technical and digitize that, on it. And so we need to make sure we maximise the benefit out of it and make sure we can deliver it. So I think increasingly, I think we need to mature the actions into the change side, the reliance on DHCW and how do we manage that coordinated change. And that's why you've got a proposal coming up in the IMTP paper about reshaping that risk in order to reflect it.
Ian, any questions? I should have mentioned there is a proposed action to close in that one as well, but they're very clear on the work. So the board today is asked to approve the updates to the strategic risks, noting any actions that we identified to close.
Thank you, Claire. And just before I move to approval, the one thing I will say is, the improvements in this risk register in terms of the way you can, as a board, we can see how it is being managed. And I think that historically, it was a bit of a dark art, but it absolutely, the fact that the latest updates are in red makes it easy to read. And it's very obvious that there is continual work going on, that there's a risk-based approach being taken. And so just a personal thank you from me, but also really a thank you on behalf of the board, because I think this makes it everybody's business rather than just the people who understand a risk register. So I think it's really helpful and gives us great assurance around the management of risk within the organisation. So it's such a move forward. I'm really pleased. So thank you. So I just wanted to note that first. And can I go, and are people happy to approve the change requests to the strategic risks outlined? Okay, brilliant. I'm seeing lots of nods around the table for that. Thank you, Claire. Thank you for taking us through it so well. Right, I'm going to move on now to Angela's last IoT.
I'm really excited. I'm really excited, Chair, to present this IMDP, our strategic plan for 26-29 to the board today. It's a very meaty pack of agenda papers and this item. So it has the strategic plan, as I say, for 26-29, support appendices. It also includes our budget strategy, our financial plan, and a separate paper on our proposed capital plan to support the strategic plan. So there's a whole host of papers there. Thank you to Nathan and Danielle who joined us today as well. They can answer all the difficult questions on my behalf. But yeah, just to say a massive thank you for all the work that the team and all of our teams have put into delivering what I would say this tonight, is probably one of our strongest IMTPs, and I think Tracy back me up on that as well. So just some highlights really. I think we can demonstrate a clear line of sight from our strategy to our delivery. We've undertaken a strong feasibility assessment, and it touches on what Ian and Claire have highlighted there around. We do have a high impact and ambitious change portfolio, but what we've done through our feasibility work is recognise that has to be delivered over 3 years, and we spent some time doing that work. And that resulted in our proposed amended strategic risks that we present here today, as well as part of the pack. We've strengthened the quality and service delivery elements of this, particularly around screening, sexual health, and also enhancing our organisation-wide quality and clinical management and assurance systems with Claire's support on that as well. We do recognise we need to be flexible and responsive as always. And like I say, it is an ambitious plan for us as well. And being flexible and being able to adapt and reprioritise is something that we just have to, sort of bear in mind as we take this through. So it's presented today for colleagues to consider and ask questions, and then hopefully we can move to approval.
Thank you. So, questions? Tracy, I'm going to come to you first, actually.
Yeah, just first to say a really big thanks to Andrew, to Nathan, Danielle, and Susan, who is with us, and of course, exec colleagues and all our teams across the organisation. I think every time we go through this more robust around realisability, I'm not suggesting that anything has gone before, but there is a significant amount of change in here. So you'll see that just reinforce that strategic risk 5. We've also had conversations about strengthening Ian's role around business transformation. What does that mean for us, given the relationship to digital programs, and also just recognising that if it's approved today and it goes into Welsh Government, we had a catch up a bit earlier, didn't we, with the Cabinet Secretary. I think there's a bit of a desire to, as part of their due diligence of it, is just to revisit the remit letter to check that there's the right stuff in there, and so there's a potential for some stuff may come out. So it's just I think it's really positive. So just to flag that, I don't think it makes any difference to what we talked about today, though. So I'll just fully endorse it. I'm sure that the colleagues will want make comments.
Yeah, thank you, Tracy. And I think, you know, the agility that Angela's already referred to is something that means that we can treat this as a live document.
Yes.
And make sure that we adapt as we go along. So, have we got any questions at all about this? I know we've had some opportunity to discuss it already. No.
Well, I actually got a question about the remit letter delivery, or are you going to come to that as a surprise?
I'll indicate to say no.
I think it's all kind of packaged. And it partly becomes relevant over what you've just said, is I noticed there were 11 areas where we said we need to know more detail. But we, you know, I'm very surprised if we don't already have something in there that does part of it, but maybe not all of it, and we haven't referenced it. I thought it might be a better starting point to say, well, we know we've got this, we need to know more about X. But something when I read them, they're just blank, just got nothing. And it feels a bit stark when I've struggled to believe in any of those. We haven't got something that is progressing that we might just not know that if it's hitting the right spot exactly. It was just an observation when I look at that. But on the IMDb, as ever, I've watched it progress over the years, and it just gets stronger every time. And I think I'm better tied in, as we said at the beginning. So, yeah, really supportive of that. It's just that bit there when we look at our plan for the remit letter. I'm surprised they're completely blank. I thought most, if not all, we would be doing something substantial. And it's about how we shape it. Is what I would expect, but I don't know enough.
Yeah, I think we shared with you my response to the remit letter. So we've got the appendix here, where we cross references it. They were kind of yes, but really for clarification. But there were also one or two that we thought that may not be appropriate for Public Health Wales. It's a 12-page remit letter. I mean, if it was a 1-page remit letter, I'd be really worried actually. But there's some elements in there that we just think that maybe NHS performance improvement are doing. Maybe it's more their role than our role. So those points of clarification are really just to make sure that we're not duplicating stuff across the system. And I think Sean Ed is going to be responding. We haven't had a response yet, but I'm sure Sean Ed is. But I don't know if Jim wants to come in, because most of them are in your part of the house, aren't they?
Yes, so we've asked for the meeting, obviously, to discuss it. We haven't had anything back concrete yet, particularly on the cardiovascular screening. We've said our advice is a targeted case funding is far better. We have met with Tom and Tom, the terrible twins from Mains Directorate. So we've worked up a joint position on where we think genomics fits, which we've worked up between us to advise them on. And that's, no, we can't just go with a massive cardiovascular screening programme, because A, there isn't the money, B, the system isn't ready, and C, we can deliver what you want it anyway. So I think we're kind of pushing discussions is the short one. Does that make sense?
Really helpful. It's just looking at it here, Stark, it just seems really, so that's good context.
And I think that after the meeting today as well, there's an intention to map some of the things in the remit letter to find out where, if anywhere, we've got things that are duplicated, that we can then seek further clarification on how we combine those.
And we've also shared the remit letters within and between the other national organisations. So there is some overlap that probably just needs mapping across, particularly between us and NHS providers. Ian.
Given the challenges of the discussion we have on an ongoing basis about impact, is this is also an opportunity to go back in some of the bits of the remit letter, which may not have the size and scale of the impact which we would want to be devoting our resources to.
Yeah, no, that's very helpful, and I think maybe just merits further discussion. And probably pick that up a bit better, I would have thought.
Yeah.
And then come back to the board with any changes, which you can do by email, I think, just as easily as beginning a meeting. But we'll have to see the timing of it. I think we'll determine that. Ramsey.
Just clearly so much work gone into this, and it's really feels much more accessible as the years go by. And I welcome the nod to inequalities at the top, and I realise that, you know, we're on a journey here, and it's great to see it up front and acknowledged. But my hope is next year we'll be integrating it actual kind of into the IMTP, because like I said, I realise that we're working towards that, but I still think that we're not integrating it into the actual actions, into the kind of objective. I still think there's a way to go there. So if we could like bear that in mind as we progress, I think, you know, and I totally acknowledge that we've come a long way. And the fact that it's up there in this thinking, and there's kind of real there's more clarity now of what we mean about the terms that we're using. But I feel like we're ready to springboard the next level.
And that's a really great point, Tamsin. And I think actually probably in line with all sorts of public bodies in Wales, there is something, isn't there, about us building our impact assessments into the work that we do, rather than considering them as a kind of separate thing. So
Just as a brief reflection, Tamsin, I think what we may be saying there is inequalities being implicit rather than explicit.
Yes.
So I think, you know, that
I
there
can
is
see
that.
yeah.
I think we do need to sort of maybe pull it through further.
if there are no more questions actually on the IMTP, I mean, I think it's interesting by the time it gets to the stage in front of board, there's obviously been lots of conversations and lots of questions and discussion in advance, and it's worth noting that. So what I'm going to suggest we do is, if we're happy to approve the IMTP, and we take that first, and we also have the amended strategic risk 5, whether we're happy to approve that. Then we haven't really spoken about the budget and financial plan. So Angela, was there anything that you wanted to draw out of that?
Yeah.
We take it slightly separate.
Yes, yeah, no problem. So I think the key sort of point to raise on the revenue plan is that we've had to deliver £3 million worth of cash release and savings to make this a very good plan. So it was just to draw that out. A lot of work has gone on with teams to identify how we could realise those savings. We have a range of national and some local cost pressures which we've set under the table in the paper. And our revenue plan, which sort of summarises in totality the just over £200 million that we've got, is set out in table 8, and that is also then shown by directorate. You can see how that budget is allocated out to each exec director, and it's also included in there how that is mapped to priorities as well, which is part of the ask about structured assessment last year. So that's just under table 9, which is part of the section which sets out how the budget then is sort of shown within our reporting structures going forward. So that is all that I would add, really. I think that section is one that we need to explore a bit further in terms of the strategic priority mapping that we've done, and we've got a couple of sessions lined up to do that with strategic priority leads and exec director sponsors as well, so we can get into how we've done that. That's great.
I mean, basically, you mentioned the point about that it's dependent on a substantial savings programme. How detailed have we got that mapped, and do we understand the profile of it? Only because lots of other organisations, I won't say here, they tend to have a plan that takes it every month, and they don't actually kick in until 6 or 9 months through the year, and then they're trying to double their plan in the last 3 months.
Yeah.
So just kind of getting your level of confidence that we have a plan that's achievable and will land us there and is appropriately profiled.
Yeah. Do you want me to take 2 seconds?
Yeah, go for it.
So we've been working on this for a while. This was, you know, sort of in train back October, November time, and we had sort of targets that we were setting ourselves. So we were working towards 2, 3, 5%, because we just didn't know sort of what was going to land in terms of would Welsh Government fund this inflation, would we not receive anything. So we were working on a range of how we could achieve that savings plan. We used the Value and Sustainability Board the headings as well. So where we know that we've got like, you know, non-pay savings, that lots of what the Valley Sustainability Board cover don't really impact us. So they're looking at medicines management, CHC, which probably are not so relevant to us. So when you break down how our savings pan out, they are primarily non-pay. So I think it's about 60%, just over 60% of the 3 million is non-pay, and there's a smaller percentage to income where we're trying to chase and deliver more income, and also then a smaller percentage towards pay. So that's how the 3 million maps out, and we've got a very detailed tracker of each of the schemes, and that we now know exactly when they're going to land. So we've been monitoring them closely as we proceed. They couldn't go in here unless they were green. So you cannot declare a saving unless you've got sufficient assurance that they're green schemes. Otherwise, they don't count in your plan, and Welsh Government would reject your plan on that basis. So all of ours have got a level of high confidence going forward. And also, as a backup, we do have some other pipeline schemes that we're working on as well. Because, as you know, sort of sometimes some things come and throw us, or we make an additional risk that we haven't thought of. So we have got pipeline schemes that we're working on. So it never stops. Like, it's almost a continuous piece of work for us.
And we'll have updates here, I'm assuming, to the data that it's on target.
Yes, yeah. It'll come through the monthly financial reporting.
Excellent. Thank you for that. Really good.
And the budgets are adjusted.
Yeah.
So, you know, they're out, it's out. So just a couple of points, just a big thanks to Ange, because, you know, you've really managed us through and navigated over the last 6 months, because we did start early on this. We weren't sure where we were going to be going into next year. Two other points is that we made, just to draw attention, we made assumptions for year 2 and 3 that we get 1.1% inflation. And Ange may want to make a point about the touch point meeting, which was very constructive and positive that you had with government recently, where they looked at our approach, our plan for the next 3 years and assumptions thereof. And then the final point, 2 points I would make, is that whilst we have not received any inflationary uplift, we had quite an extensive discussion as execs as to whether we pass that inflation on to our commission services through screening. We pay health boards, and also some other additional elements with shared services, DHCW. We made the decision that we were going to do that. Obviously, as far as we and I'm concerned, we've been asked to submit in the remit letter savings plans for the first quarter. As far as I'm concerned, those are our savings plans for the first quarter. We've given 1.1% back into the commission services, even though we haven't got it. So that's that point. And then the final point, which we've talked about this morning, is that we're already seeing quite significant inflationary increases in our supply chain, given the geopolitical, well, the wars are beyond tensions, aren't we? And so I'm just to flag that we're going to have to really closely monitor that through next year, because we may need to find further savings, particularly for Meg's part of the house. We're already seeing it in the infection service, particularly. So it just to flag that to the board.
Any other questions? And the final paper in this section is just around the capital programme.
Yes.
So Angela, is there anything that you want to highlight out of that?
Thank you, Chair. So this year we're in a really great position because we've got this plan ready to come to this board session. It's been one of my sort of drivers to try and get this approved quickly, so that we don't have the quarter four sort of scurry and you know, sort of backlog of procurement plans coming to fruition quite late in the financial year. So this is presented here today. It's sets out our proposed plan for our discretionary capital, which we've had a slight increase this year as well. And it's based on a request that have come in from statements of need and an assessment of our replacement, our RAM system, which is our real asset management system, where we know things are coming to the end of their life. So it goes into detail on the proposed discretionary capital scheme, and it also gives an overview of our strategic capital schemes as well. where we've got a number of unapproved strategic capital schemes and a number of business cases being drafted as well. So we will just be going through the process with Welsh Government on those as and when they come through the system. It just sets that out for the board to see in totality what our capital call is.
Thank you, and I think it's really helpful for the board to be able to see where the capital is being spent. And it's very well laid out, so thank you very much for that. Any questions for Angela on that?
I agree, it's really helpful. Or just one observation, which I'm not sure whether I'm right in saying is the final Appendix A full list of capital bits. Am I right in assuming in there somewhere are bits that haven't been funded at this stage?
Yes, they were all bids, so they would have been prioritised. That's the full list that we've received.
So I think what might be quite helpful is to be able to ascertain from that what we haven't done, and if you've already got a priority order, what that looks like. I think it gives us a sense of what we haven't been able to tackle in that priority sense, whereas I had to go through and pick them to see, well, that one's funded, that one's not. I just think because it gives us a sense of what we've not been able to do now from the risks that we carry as an organisation. It's just a helpful thing, I think, for the board to be said to that.
We can build that into the next report to the board for month 1.
Yeah, that would be really good to see that. So if there aren't any further questions on that, then I've got a number of approvals that I'm going to take together. So the IMTP for 26 to 29, lots of nods around the table. The amended strategic risk 5, approving the budget strategy and the financial plan for 26-29, and the planned capital programme for 26-27. I'll take those as approved. Okay, that's lovely. Thank you very much. We'll take those as a block. Next item on the agenda, I'm going to come to you, Samina. It's the climate response plan.
Thank you, Victor. So this is for approval of 2 documents. And with both, there's an expectation from Welsh Government that they're submitted to them after board approval. So the first one is our climate response plan. This is our third decarbonisation action plan. It takes us from 26 to 28, so that only is for 2 years. And like Welsh Government recommendations, we have combined decarbonisation with adaptation. So that's on their recommendation. So we now have a single plan. So it's about how we reach net zero and also how we're more climate resilient. These do align with the IMTP. And I've got to highlight that this sort of builds on 4 to 5 years of concerted effort on decarbonisation. We still have a long way to go, but we are getting better at this. And we've had quite a few discussions with the exec team as well on this. The way it's structured is there's 6 activity streams, and what we've done is have milestones to 2030. The second document is an adaptation work programme, qualitative report, and it's quite detailed, and it basically outlines our actions over the past financial year, but it is underpinned by very comprehensive risk assessment done with our staff over the past year.
Questions? Any questions for Selena on this?
I think it's been a great report going through. I suppose my concern around it is when we get to, when I read the activity streams and the work in there, it doesn't give me a sense of whether that's enough to get to there or not. It's the impact. I come back to our impact question, which we always challenge ourselves on right here now. And I read the actions and I go, I don't even get a sense what the cherry and the quantum. And I know they're 26 to 28 and we're looking at 30 and we're looking at 35 and stuff, but it's how far down that road do we think these actions are going to take us? And then I know it's right to go mad, but I don't get any sense, unless I didn't read it right, which still is possible. But my read, I didn't get a sense from these, are these enough? How far down the road will they take us? Because as you say, there's a lot of work happened today. There's a lot that's happened in the way we count and everything that doesn't necessarily then reflect what we've done. But if we set our ambition, how do we measure that these are taking us on that journey in the right direction and that they'll be sufficient to get us to the end point we want to achieve? And I just didn't get that from this. That would be my observation.
I think that's a really fair question. And it's something that we also have debated. So I think there's 2 things. One is the measurement question. because the goalposts are changing all the time. So, and we get better at measuring. So actually, because of the way things are measured, our carbon footprint is actually increasing. So we've had an in-depth discussion with the exec team about how we do that better. So there's work underway so that we can actually track our impact. But the second thing is that we know where our biggest emissions are, and they're in procurement, but we need to unpick that further. So we have put some additional resourcing at year end to try and just get really in there to understand where can we have the biggest impact. Because at the moment it's huge, it's about 80-something%, of our carbon footprint is procurement, and we need to get into that in a bit more detail. So I completely understand the concerns, and I can say that we are getting better at the measurement, but also the actions we need to take in response.
I think it's a bit for me. I mean, I reckon I know how, I don't know, but I sense how challenging it is as a space to get that. I suppose it's a bit for me then, maybe there's a commitment back to board, whether it's in a year or whatever, we come back with a better idea of how we measure, how we'll get the impact, and how we can gauge whether what remains in this at that point, how far we think that might take us, and therefore the idea of how much more we still have to do, because it was so stark with the change in the way we count, but the fact that it appears as though we've gone backwards, and clearly we'd like to measure against where we were to where we are and understand what moved around us. But I think that would be helpful. So obviously supporting this for where we are today, but recognising if we can't get a lens on that, the risk is 2 years' time, 3 years, 4 years' time, we find ourselves still looking like a worse position for all the effort that everybody puts into it.
I welcome the opportunity to bring this back, and it's work underway anyway. So, I think that'd be great.
Yeah, and I think so I was going to ask some sort of similar question. Obviously, there's been a lot in the news recently because of the political unrest and wars about, actually what impact that's having on the carbon dioxide in the atmosphere. And I think for me, there's something in receiving a document like this at a point in time that doesn't allow us to say, well, actually in 3 months or 6 months' time, the situation might look worse, but part of the reason for that is because there are things outside of our control that have happened. So it doesn't necessarily feel quite like a live document. And I think part of that is perhaps because it comes back every 2 years. So there is something about how do we measure what we've done, even if what we've done maintains a steady state. If we hadn't done it, where would we be? And I think that that's something, if we can get a bit of a handle on that, it'd be really helpful. Tamsin, I came in for you.
No problem. I agree that, it's great work being done as an organisation towards net zero, and us as an organisation being climate resilient. But I think that we work that as an organisation, and I know you've started it, and it's kind of get some traction, is how resilient is Wales to climate change, because that's the real kind of nub of the issue, isn't it? Because we're just a little boat in a storm, aren't we? And it's like, how do we kind of stay afloat, really, and have our most vulnerable, who are it's always the poor, isn't it, who are affected most by climate change. How are we as an organisation really kind of, for me, I think that's where our focus around climate, it should be, is around the resilience of the poor in the face of climate change. Because I think with all our obvious intentions around net zero, like you say, there's a whole world turning right now, and yeah.
So I think the reflection would be very much that we would like you to bring back this, and if you've got progress, shall we say, and in that broader context, I think it would be really helpful to the board, and actually helpful to us, the organisation, about just how are we moving forward and how agile we can be. Sharon.
I just wanted to try and put this is our context for us as an organisation. And then we've got the IMCP, which is us and our organisational role. And I'd quite like to see the two together because it sort of brings us a more cohesive approach. Because it's just, I mean, just one little thing that came to me, increased death rates during hot periods, for example. We might lose some of that aspect if we only look at this, whereas we are actually able to influence the wider system. So I don't know if you could try and do that to me. Otherwise, I've got two strands going on in my head. And
I keep saying, never break them.
But Mina, so when I started another job, I was only pushing to separate them
yes, I think
because they are very different aspects.
but I just think you need, if you had a big circle, there'd be a bit there, a
Venn
bit
diagram.
there. Where do they fit together or don't they fit together?
I don't know.
We can.
I think they do, you see. Our staff members will be affected by the weather, for example. Well-being staff will be affected by the weather.
Thing.
They will. Have increased, that's great, that's great. Thickness rates, you'll have all those things associated with it.
I'll never stop.
What a shame you're not on quick anymore.
Meg, you wanted to speak.
Yeah, the climate health surveillance is a really interesting one. I think this is where we have the information, but we're not really sure what the action is that we're trying to influence. And it's not our action necessarily. And this is where we need to understand from a Welsh Government perspective how they're going to bring the system together to act, to plan, to respond. So that work is ongoing because we've now sent back our kind of analysis of the options. We're waiting to hear back. Now, I chair what's now called, needs to be decided, but it's acknowledging that sustainable clinical services as a role to play. So I'm chairing that group which reports into the Welsh Government-led programme board. And one of the areas that we would put back into Public Health Wales is work across health protection and screening services about our services and how they can respond to climate change, both in terms of decarbonisation and adaptation as well. And we put something in the IMTP to reflect that commitment.
Thanks, Meg, for that. And we look forward to you.
As it's always black pieces.
As for that at the moment, are people happy to approve the plan?
Yes.
Yes, okay, great, thank you. And there's also the work programme report to be submitted to Welsh Government. And are people happy to approve that? Okay, that's great, thank you very much. And I know that Samina, you have to go to another meeting before too long, so I'm very happy for you to just leave at whatever point you need to. Okay, so thank you very much for that, and thank you for taking us through that paper. Environmental policy is another approval. And is there anything that you want to draw out of this at all?
No, just to say that it's gone through rigorous sort of review and assessment, and thanks to Selina and Rebecca for that, they supported this as well. What we will do to supplement this now, because it's a new policy, is work with Chris Orr is going to do this on as chair of the business planning leads, but we're going to be doing a procedure, so it sort of backs up the so what that supports the policy going forward, because it's the brand new policy.
I'm sure everybody's read this as well. Are people happy to approve this environmental policy? Thank you very much. We've now got the minutes and the action log from the 29th January board meeting. Is there anything in the minutes that any matters of accuracy that people wish to raise? People happy to approve the minutes? Great, thank you. And the action log, I'm just going to pass to Paul to just pick up on the action log. Thank you.
Yes, thank you, Chair. 2 actions that are marked as completed. Proposal to close them today. Happy.
Good. People happy to close those actions? Great, thank you very much. The hosting agreement for NHSP and I performance improvement hosting agreement, if you would like to take us through that. Thank you.
Thank you, Chair. So what we've been doing with this agreement, it's largely the same as it was in September 25 when we approved it. But as a result of the hosting review and shared services in NHS Wales, the Director General wanted this agreement to be reviewed again. So you'll see within the document there have been some changes made. Some people have tracked changes, some of you might not, so apologies for that. But the main changes are in 5.1 and 5.2. And the changes seek to clarify the role of the Director General and to draw a distinction between the performance management of P&I as opposed to the hosting arrangements, performance management resting with the Director General and the Welsh Ministers, and the hosting arrangements resting with us under Tracy's accountability. So those are the key changes to the document. The cover paper also includes the provision on proposal for the hosting fee for next year. Angela's team has crawled all over this together with myself and Rachel from a pod perspective, and we're satisfied that this meets the requirements for the next financial year. We do have a change process in place, so if there are any spikes of work in P&I that require that boosted hosting support, we can ask for additional funds in year to support that. So the agreement and the hosting fee are here for approval, and they take effect 1st of April if approved.
Obviously, we've seen the previous versions, as Paul has said, so are people happy with this final version of the hosting agreement?
Yes, as we've seen over the years, how much better it gets, knowing all the effort that was done behind it. It's certainly come a long way. The fact that so much of it survived in the last year says a lot about what you achieved. Thank you for that.
And I think as a board, we really ought to pass our thanks on to Paul, who I know has put in a huge amount of personal time and work into this hosting agreement, bringing it to the stage where we're all sitting around going, yes, we're all very happy with this. So thank you, Paul, for that. Okay, we have some items to note just for the board performance plan. I don't know, Liz, if there's anything that you wanted to raise out of that. And other private meeting notes as well, just to note. So I'm sure everybody's read them, and if there is any comments, then people can raise anything separately as well. That's great. Okay, lovely. Thank you very much. I do have a couple of pieces of any other business. The first one is just a plea to the board. We've got a new Starters Day on 1st of April. It'd be lovely if one of the non-execs would and attend for, if it's only for an hour or two. I think Rachel would be really grateful for a board member to be there. It all helps the visibility of the board.
It's not an April Fool's joke.
No, it's not an April Fool's joke. I'm unable to attend, so I would really be grateful if somebody would think about attending. I know Steph has already put out a plea. I want to pass on some thanks to Wedinos, who hosted myself and Claire. I have a number of postcards here. When people send in their samples into Wedinos, they have it's a blank piece of paper on the back. People put little notes on the blank pieces of paper, and they're on the back of these. So if you'd just like to pass them out around the board so that people can see some of the impact of the work that the Wedinos Lab does on the people who are sending samples in. So there's 4 or 5 different notes, but I just thought it was a really nice thing for the board to see the work that they do and the impact that it's having on people's lives. And, you wouldn't necessarily think, oh my goodness, if I send a sample off to a lab, we wouldn't sit here and think how grateful people are for that service. And so I just wanted to really highlight that. I think it's just been an incredible thing that they're doing. And then finally, before I go on to the date of the next meeting, I really want to pass on a massive thank you to Angela, who is retiring, our Director of Finance, has done a most amazing job. She's done an amazing job here today, taking us through everything from the IMTP to performance, to finance, to capital, to estates, all sorts of things. It just shows the breadth of the work that you do for us, Angela. 38 years working within the NHS as a summer job, as you pointed out, seems like a very long time. And I think, we're all very, very pleased to have had the opportunity to work with you. And, and I think you should be rightly proud of everything that you've achieved for the organisation, for your community, and for the Board of Public Health Wales as well. So I just really wanted to say a big, huge thank you, and we will make sure that all of that hopefully makes it into the minutes and it's a properly noted. So thank you. I'm going to say the date of the next meeting is 28th May, and I will see you all then. Proso.
Top down.
Yeah.